Welcome to our webinar on reflux questions and answers. In this webinar, we'll look at when you should consult your GP and what investigations and treatments the GP may suggest. We'll also discuss whether reflux is a lifelong condition and explain how a hiatus hernia may occur and its relevance to reflux. Additionally, we'll look at Helicobacter pylori infection. Our expert speaker today is Dr. Emma Greig, Consultant Gastroenterologist. Okay, Emma, let's start right at the beginning. Can you take us through when a person should seek advice from their GP for their reflux symptoms?
That most people tend to get better quite quickly, particularly if they start some dietary management or some medication. So if your symptoms persist for more than a few weeks, your symptoms are becoming worse over time, or your symptoms are failing to improve with medication, then that's when we would say to seek help from your GP.
What is the GP likely to do when you consult them for your reflux?
Depending on how your symptoms are, what age you are, and what other associated things you report, they may want to do some blood tests, and that can be to look for things like anemia. They may be looking for other conditions depending on what sort of symptoms you've got. So they may want to look at your liver function. They may suggest a stool test, which might be a surprise to you. But what they're actually doing with that poo test is to test for a bacteria called Helicobacter. And the Helicobacter lives in the lining of the stomach if you're infected with it. And I'll go on to talk a little bit more about that in a minute. The other thing they may suggest is a camera test. And there are alternative names for that. So it can be called an esophagogastroduodenoscopy or OGD, a gastroscopy or an endoscopy, but they all essentially are used interchangeably. And what they mean is a procedure where a thin camera passes either through your mouth or through your nose, through the gullet and the stomach and into your small bowel, so that a doctor or nurse can have a look at those tissues and see how they are, and look at that in conjunction with the symptoms that you've got. Now, I would have to say that usually when we do a gastroscopy for reflux, it's often normal. And we do have a lot of talk about whether it is of benefit to do a gastroscopy or not. So we tend to reserve it for certain groups of people. So those over the age of 55, for example, we're potentially more likely to do a camera test. Or if there's other associated features like unintentional weight loss. So that's weight loss where you're losing weight without trying.
Because a lot of patients would like to have an investigation if they're worried about their condition, but you're saying actually there's quite a large number of patients for whom a gastroscopy won't necessarily show up anything anyway, and yet they'll still have the symptoms.
Yes, absolutely. And because they aren't nice tests, and I'm sure those of you who are listening either know people or have had them yourself, we do try and avoid them if we don't think they're going to be of benefit, because there's always some very minor risks associated as well. And even though they're very rare, again, we don't want to put people through unnecessary investigation. Your GP may want to try you on some treatments. I mean, you may have tried some of these yourself already. So it starts off with very simple ones called antacids. And what they are is they're medications that either come in the form of chewable tablets or liquid, such as Gaviscon or Rennies. And they work directly against the acid that you're feeling at the time. So if you are particularly uncomfortable, it may be worth trying some and then seeing how quickly it works, usually within about 5 minutes. The effect doesn't last though, because they get washed away very quickly. So the next line of medicines are things like cimetidine, famotidine. Their medical name is H2 receptor antagonists, and they reduce acid production, but they don't work that quickly. But again, they can be really effective, and they have few side effects. They're often a good medication, but they have recently been harder to get hold of. And then probably our mainstay of treatment is omeprazole and lansoprazole, and they're called PPIs or proton pump inhibitors. And what the proton pump does is the thing that actually produces acid in the stomach. So these drugs actually block acid production. So you may still get reflux and fluid, but it's no longer acid, so it no longer causes burning. And a short course of those would be the standard treatment that a GP would try if you had these symptoms and basic lifestyle wasn't helping them.
So would you be given the medications first before you got referred for a gastroscopy?
Quite often, yes. And quite often just a 2 or 3 week course of these medicines is enough to settle people down. And then when your symptoms have gone away and they don't come back when you come off the medicine, there is no need for a gastroscopy, because quite a lot of us can have a short term reflux, and then the symptoms don't come back if you make the lifestyle changes and stick with them.
Emma, when should you see your GP really urgently?
So if you've got reflux symptoms and you're struggling to swallow, that's one of the signs that we worry about. If you've got unintentional weight loss, as we've already said, that's really important. If you're trying to lose weight and you're losing weight, then congratulations. But if you're losing weight without trying, it's a significant medical symptom.
So with unintentional weight loss, is there a particular amount of weight loss that we're talking about here?
Well, no, I mean, if you're the sort of person that's been a very stable weight for many years, and then you start to lose weight for no good reason, there wouldn't necessarily be a right amount compared to someone else who perhaps yo-yos in weight. So it's an amount of weight loss that's concerning to you. Probably at least half. If you're losing more than half a stone, certainly a stone without trying, then you should definitely seek medical help. If you've got black poo or you're vomiting blood, you need to seek urgent help. That may be in the form of A&E. If you've got persistent vomiting, then again, it would be your GP. And again, you know, there's a number of reasons why people might have persistent vomiting, but again, it's worth getting it checked out. Now, you and I, Marianne, have already talked about chest pain that's not associated with food, but is associated with exercise. And because so many of the risk factors for reflux and for cardiac chest pain are the same, I just think it's important to reiterate at this point, it may not be your esophagus at all. It may be this is cardiac pain.
Yes, Emma, can you just remind us how this pain differs from pain associated with a heart attack or what we call cardiac pain?
You've got pain going into your jaw, down your arm. It's causing shortness of breath. It's particularly coming on with exercise, so climbing stairs, hills, walking faster than usual.
So if you've got this sort of pain, then you should definitely go and see your GP urgently, because it may be that you've actually got cardiac pain and not chest pain associated with reflux.
So Emma, is reflux lifelong?
We've heard about what the risk factors are for reflux, and quite often for an individual patient, unless they do something to modify those, then they will have symptoms on and off in the longer term. So because there's a lot of modifiable factors, if a patient, say, finds that losing weight is effective and keeps that weight off, then potentially their reflux may be cured. But we know that there's the potential for it to come back again. So a lot of it is around which particular factors work for you to reduce your symptoms and sticking with them. This is something that's likely to be picked up at an endoscopy. And what a hiatus hernia is, it's where the top of the stomach slips through the diaphragm. Normally the diaphragm, you can see it labelled on this picture on the left-hand side, helps to act as part of that valve that we've been talking about. However, hiatus hernia happens when the top of the stomach slips through the diaphragm, so you lose some of the valve effect and you're more likely to get fluid flushing upwards. There are risk factors for getting a hiatus hernia, and obesity is one of those, so increasing abdominal pressure will tend to make that happen. Some patients have a scoliosis, which is a deformity of the back. That can make it more likely. And the type of hiatus hernia shown here is a sliding hiatus hernia, which is by far the most common type. So how would you manage if you had a hiatus hernia to reduce your own symptoms? So that would be, the physical things become even more important. So making sure you tilt the head of your bed, losing some weight, the same things we've talked about with changing diet, medication, and you may be a candidate for surgery if all of those things don't work. And again, there is a webinar on whether or not surgery would be of benefit to you. So again, watch out for that one.
Emma, what is Helicobacter pylori and does it affect reflux?
So we've known about Helicobacter since 1985, and it's associated with ulcers in the duodenum and in the stomach. It's a bacteria which lives in the mucous lining of the stomach, and it causes a chronic inflammation. We know it can sit on acid-producing cells in the stomach, and there is some evidence that Helicobacter can actually reduce acid production as a result of that, and therefore reduce reflux. However, it is associated with an increased risk of gastric cancer as well as ulcers. So if we test you for it, either with a stool test or with a biopsy at the time of an endoscopy, then we tend to advise getting rid of it, because we know that patients that have quite a lot of problems, such as reflux or dyspepsia, can be on acid suppressing medicines like proton pump inhibitors in the long term. And again, we don't like people to have Helicobacter and be on long-term proton pump inhibitors, so we tend to try and get rid of the Helicobacter more as a safety mechanism. So you need to come off your proton pump inhibitor a couple of weeks before you do the poo test, or it may not be accurate. But your own GP will talk to you about that.
Emma, what happens if I've still got symptoms after my treatment for Helicobacter pylori?
It's really important that you take the course as it's prescribed, and it will seem like quite a lot of tablets when you're first introduced to it. You're usually prescribed a course for 7 days and occasionally for 14 days. Now, people may have ongoing symptoms even if they clear their Helicobacter. So if you've still got the same ongoing symptoms and you've taken the course as it's prescribed, then you should probably go back to your GP and you'd need a stool test to make sure that you have cleared the bacteria or not. A blood test wouldn't be accurate in this situation, as it'll just show you've had past infection and it won't show whether you've cleared the bacteria or not. If you have cleared the bacteria, then it's a question of managing your symptoms. However, if you haven't cleared the bacteria, sometimes people need a slightly different course of antibiotics and treatment in order to clear it completely, because sometimes it's not 100% effective.
We hope you found this information useful. Please also look out for our webinars on diet and lifestyle, medication, and surgical options in reflux, all to be found in the same reflux section on this website. You'll also find a link to the further information handouts for reflux, where you'll find useful downloadable information and links. Thank you for listening. Goodbye.